So let's talk about mental health service provision. We are talking about UK, of course. History. Until the 18th century, the mentally ill in the UK received no formal psychiatric care. Those who were not looked after by their families were kept in workhouses and private institutions. In 1845, the Lunatics Act led to the building of an asylum in every county so that those patients with severe mental illness could be cared for in large remote asylum communities. Since the introduction in the 1950s of chlorpromazine, the first effective medication for schizophrenia, there has been a significant decline in the number of patients in psychiatric hospitals. The attempts to reduce the cost of inpatient care, as well as the criticism leveled at asylums regarding the institutionalization of patients and the loss of patient autonomy, led to the closure of the large asylums and the rise of community care. Today, most mentally ill patients are assessed and managed in the community, and hospital admission, when indicated, is usually only brief in duration. Let's talk about primary care. Up to 95% of mental illness is seen and managed exclusively in primary care by general practitioners, with mild to moderate mood and anxiety disorders and alcohol misuse being the most common conditions. Depression, which is the most common mental illness treated, is frequently associated with symptoms of anxiety as well as physical complaints. It's important to note that up to half of all mentally ill patients go undetected in primary care. This is because many of these patients present with physical rather than psychological symptoms. Also, some patients are reluctant to discuss emotional issues with their doctor due to feelings of embarrassment or uncertainty about how they will be received. Some GPs have the option of referring patients with mild symptoms or those going through a life crisis, for example, bereavement, to a practice counselor. We will talk about them. We've actually have something to talk about them in chapter 3. Anyways, when we've talked about psychotherapy. Practice and this district nurses may be helpful in screening for and educating patients about mental illness. Primary care liaison teams exist in many areas. These act as single point of contact for GPs to refer to. Referrals are allocated to psychiatrists, psychologists, community psychiatric nurses, or occupational therapists as appropriate. This means the GP does not have to work out which professional is best placed to help the patient before referring. So this means the GP does not have to work out which professional is best placed to help the patient before referring. The team can discuss this among themselves. Some patients will continue to receive intervention at primary care level, and others will require secondary care. The following box lists the common reasons for referral from primary to secondary mental health care. So here we have the reasons for referral to secondary mental health service. First, moderate to severe mental illness, like schizophrenia, bipolar affective disorder, severe depression or anxiety disorder. Patients who pose a serious risk for harm to self, others, or property. Uncertainty regarding diagnosis. This is another indication. Poor response to standard treatment despite adequate dose and concordance. Specialist treatment required, like psychological therapy, specialist medication regimens. Okay. Let's talk about secondary care. We have community mental health teams. In the UK, specialist psychiatric care in the community is mostly coordinated by regional community mental health teams, CMHTs. These CMHTs, which consist of a multidisciplinary team of psychiatrists, CPNs, social workers, psychologists, occupational therapists, and support workers. Again, so these teams, community mental health teams, consists of psychiatrists, of course, and we have CPNs, clinical psychologist, nurse, or something. Okay, social workers, psychologists, and occupational therapists, and of course with support workers. Team members usually operate from a base that is easily acceptable to the community they serve. Although local GP surgeries are also used to see patients who are unable to come to the CMHT location are often seen at home. So this is about community mental health teams. What about care program approach? The approach taken by some secondary care psychiatric services is called the Care Program Approach, CPA, introduced by the Department of Health in 1991. This approach applies to all patients under specialist psychiatric care and includes patients based in the community, in hospitals, and in prison. The key components of the CPA, the care program approach, are these. The key components of that approach is the systematic assessment of patients' health and social care needs, the information of an agreed care plan that addresses these identified needs, the allocation of a care coordination, previously called key worker, to keep in touch with the patient to monitor and to coordinate the care for these needs. This is usually a CPN, social worker, or psychiatrist. Regular review meetings, which include all relevant professionals, patients, and their carers, to adjust the care plan if necessary. Patients may be placed on a standard or an enhanced CPA according to the severity of their needs. Hints and tips. The diverse and multiple needs of patients with mental health problems make a multidisciplinary approach indispensable in psychiatry. A multidisciplinary team consists of members with medical, psychological, social, and occupational therapy expertise. Let's talk about outpatient clinics. Psychiatric outpatient clinics take place in CMHT centers, GP surgeries, and hospitals. Types of clinics include psychiatrists' clinics for new referrals and follow-up patients, and special purpose clinics like depot and psychotic injection clinics, clozapine monitoring clinics, and so on. Some areas offer regional assessment service for neurodevelopmental disorders. One of the secondary, to remind you, we are talking about secondary care. We've talked about community mental health teams within secondary care. We've talked about care program approach within secondary care, of course, outpatient clinic, and now we will talk about liaison psychiatry. Liaison psychiatrists work in general hospitals. They provide psychiatric opinions for people who attend a general hospital with physical health problems, with or without a pre-existing mental health problem. Common referrals are for assessment following self-harm, advice on management of delirium, and distinguishing depression from symptoms of physical health disorders. People with intellectual disability can find hospital admissions particularly challenging, and therefore some hospitals provide an intellectual disability liaison nurse who can advise on strategies to manage distress and challenging behavior. Day hospitals. Day hospitals are non-residential units that patients attend during the day. They are an alternative to inpatient care for patients who, although need intensive support, are able to go home in the evening and at weekends. Having a supportive family is helpful in such cases. They may also be used for patients who have just been discharged from hospital but who still need a high level of support. As a form of partial hospitalization, they are now mainly used for older adults. We have assertive outreach teams. These are like CMHTs and involve a multidisciplinary team but provide a more intensive service, providing more flexible and frequently patient contact. They are targeted at challenging patients who have not engaged well with mainstream mental health services in the past. Patients who use this service often have histories of severe and enduring mental illness, significant social problems, and complex needs, and are usually considered relatively high risk in some regard. For example, self-harm or suicide, violence to others, self-neglect, or vulnerable. The nature of their illness requires more focused and intensive input. So this is the assertive outreach teams. Okay, more flexible and frequent patient contact. Home treatment teams. There is increasing emphasis on treating patients at home, thus providing expensive and disruptive inpatient admission. A hospital admission can be very challenging for anyone, particularly someone with an acute mental illness. Treatment at home also allows practical problems with housing and activities of daily living to be better identified and addressed. Most regions now have home treatment teams, also called crisis teams, who can provide short periods of support, from a few days to weeks, to people who might otherwise have to be admitted. They can also facilitate earlier discharge than would otherwise be possible. Such teams include similar professionals to a CMHT, but generally are available out of hours and can visit patients more often. For example, multiple times per day if required. Medication, practical help, and psychological therapy can be offered. What about early intervention in psychosis? There is some evidence that the longer a psychotic episode goes untreated, the poorer the prognosis, suggesting that early treatment is preferable. However, not all mild or vague symptoms of possible psychosis become a definite psychotic episode, meaning it can be hard to know when to start treatment. For example, a person who is suspicious of others but not holding a certain belief or persecution. Specialist teams exist in many regions to manage such cases, offering assessment, medication, psychological strategies, and education for patients and families. Teams are open to psychosis secondary to any diagnosis, for example, schizophrenia, bipolar, substance-induced, and generally accept people aged 14 to 35 years. What about inpatient units? Occasionally, community care is not possible and hospital admission is necessary. Reasons for admission include the following: provide a safe environment when there is high risk for harm to self or others, or grossly disrupted behavior. A period of inpatient assessment is needed, for example, of response to treatment or when the diagnosis is uncertain. It is necessary to institute treatment in hospital. This is another indication. For example, electroconvulsive therapy, clozapine therapy, although both of these can be initiated as outpatients if the patient is at low risk for complications. There are various types of inpatient units. These range from a general adult acute ward for uncomplicated admissions to psychiatric intensive care units for severely disrupted patients who cannot be adequately looked after on an open ward. High severity units, also called special hospitals, are for mentally ill offenders who pose a significant risk to others. Mother and baby units provide care to women who have recently given birth, and eating disorders units providing care for those with severe physical complications resulting from anorexia nervosa. Rehabilitation units. These units aim to reintegrate patients whose special and living skills have been severely handicapped by the effects of severe mental illness and institutionalization into the community. Admissions are often for months or even years. The approach taken is holistic and uses the recovery model, learning to live well with ongoing symptoms rather than aim to complete remission of symptoms. Accommodation. Certain patients who are unable to live independently due to severe and enduring mental illness may need supported accommodation types. Types of supported accommodation range from warden controlled property to residential homes with trained staff on hand 24 hours a day. Chapter summary. Most mental health conditions are managed in primary care. Patients with severe and enduring mental illness can benefit from input from a community mental health team. Many services exist to manage acutely unwell patients at home. High-risk patients are likely to need hospital admission.